Hello, and welcome to the Volunteer Action Network Volunteer Orientation. This video presentation will give you a good introduction to Compassion and Choices and how you can support our mission. Compassion and Choices' mission is to improve care and expand options for the end of life. We believe in patient-centered care. We believe that every person should receive medical treatment that is aligned with her or his values and priorities, and that people and families should be fully informed and supported by providers on the full range of end-of-life options, including medical aid in dying. We've designed our programs, advocacy, and services to work towards achieving these ends, and I would like to emphasize that volunteers like you are truly the key to our success. At Compassion and Choices, 95% of our contributions are made by individuals, foundations, and non-governmental grants. These are averages based on the last 5 years. And also on average, we have spent 82 cents of each of these hard-earned dollars on our programs. And because of this, Charity Navigator has rated Compassion and Choices 98 out of a possible 100 points. Compassion and Choices Volunteer Action Network provides a roadmap towards authorizing and later implementing medical aid in dying in every state. It's a one-stop shop for information and resources so that you can get started, get trained, get going, and then keep going as a Compassion and Choices volunteer. In partnership with your volunteer manager and action team leader, this approach empowers you with the resources you need to set and implement strategic goals that will position your state to pass and eventually implement medical aid in dying laws. Before we get any further, let's review the objectives of this session. By the end of this training, you'll have a clear understanding of what medical aid in dying is, as well as who can access it and under what circumstances. You'll be knowledgeable about Compassion and Choices' work to pass medical aid in dying laws. You'll know who our supporters are, as well as the objections of those who don't support medical aid in dying. You'll have a better idea about our messaging and how to talk about medical aid in dying. We'll go over some frequently asked questions and arm you with answers to those questions. And finally, you'll be ready to take action in support of our medical aid in dying work, and you'll know how to get started. Also known as death with dignity, medical aid in dying is a medical practice that gives terminally ill, mentally capable adults with 6 months or less to live the option to request that their doctor write a prescription for medication that they can decide to take to die peacefully in their sleep if their suffering becomes unbearable. In Oregon, where the medical aid in dying law has been in effect for 2 decades, there have not been any instances of abuse of the law, and studies have shown that end-of-life care has actually improved in dramatic and measurable ways. Oregon has one of the highest utilization rates of hospice care in the nation. More people die in their homes than in any other state in the country. And terminally ill people report a great palliative effect that relieves worry and anxiety at simply having the option available to them if they need it. Bioethicist Arthur Kaplan said, "The Oregon law has benefited many more people than have actually used it." Medical aid in dying has evolved into an accepted practice with well-established protocols for physicians. The Journal of Palliative Medicine published clinical criteria for medical aid in dying that physicians use to ensure that the practice meets the highest standards of medical care. Although each authorized state's regulatory and procedural requirements differ slightly, all mandate eligibility criteria, including that the person must be a mentally capable adult, as confirmed by a mental health professional if necessary, and with a terminal diagnosis and prognosis of 6 months or less to live, as confirmed by 2 physicians. All existing laws also mandate core safeguards, such as required education on other end-of-life options, including methods for pain control and hospice care, and the right to rescind the request at any time. So how does this help a person with a terminal illness know whether this is the right decision? These core safeguards mean that anybody who is considering medical aid in dying, by law, must understand all of the available end-of-life options, and may choose medical aid in dying along with other options such as hospice. This education and the resulting conversations between a terminally ill person and her or his physician and family members allow the person to make an informed decision that is consistent with his or her values and end-of-life priorities. But what if a person changes her or his mind? Existing laws also mandate that the terminally ill person has the right to rescind the request at any time, meaning they can change their mind at any point in the process. The person also must, by law, be able to self-ingest the medication. So even if the person has received a prescription, he or she may simply decide not to take it for any reason. In states where medical aid in dying is authorized and we're tracking data, we have seen that approximately 1 in 3 people who receive a prescription for aid in dying medication do not use it. Since the law was passed in Oregon in 1997, a total of 1,749 people have had prescriptions written, but only 1,127 patients have died from ingesting the medications. This is consistent with the data that has begun coming out of California. Only 42% of people who receive aid in dying drugs in the first 7 months since the law took effect there died following ingestion of the prescribed drugs. What has been reported across the board is that just having the medication in hand provides a great deal of comfort and peace. In addition to being a compassionate and palliative medical practice, medical aid in dying is safe and trusted by doctors and communities. There has not been a single incidence of abuse or coercion in the 20 years that Oregon has authorized medical aid in dying, or in the 40-plus combined years of medical aid in dying in all of the authorized states. The core safeguards are proven, and the law works as intended. To recap, only terminally ill people who are mentally capable of making their own healthcare decisions are able to voluntarily ask for a prescription to take if their suffering becomes unbearable. The attending physician is required to inform the terminally ill person requesting a prescription for medical aid in dying about all their end-of-life care options, including hospice care, palliative care, and pain control. The terminally ill person must be free from undue influence or coercion. Accordingly, our model legislation requires that the patient must sign a form attesting to the voluntary nature of the request. The individual always has the right to rescind his or her request or not take the prescription at any time. It is always the terminally ill person's choice whether to request or take the medication. And participation for physicians, pharmacists, and other healthcare providers in the practice is voluntary, and individual medical providers have the choice whether or not to participate. Compassion in Choices has supported a number of states in their efforts to authorize medical aid in dying, either through legislation, ballot initiative, or court decision. Oregon was the first state to authorize medical aid in dying in 1997 by ballot initiative. 10 years later, in 2008, Washington State followed, also by ballot initiative. And in 2009, Montana became the first state to authorize medical aid in dying by court ruling. In 2013, Vermont was the first state to pass legislation authorizing the practice. The movement experienced a huge win in California in 2015 through legislation, and Colorado was close behind with its successful ballot initiative in 2016. And most recently, the Washington, D.C. City Council passed the law in 2016. Compassion in Choices is actively pursuing a capacity-building model as we work to extend end-of-life options in all 50 states. This means that regardless of what state you live in, There are actions you can take to push your state towards authorizing and ultimately implementing medical aid in dying. It also means that we have supportive toolkits and guidebooks to help you along the way. Our expert staff members are working with volunteer action team leaders across the country to define state-specific goals and activities you can participate in to support this effort. Make sure you're working closely with your action team leader, or, if there isn't one in your area, consider stepping up and starting your own team. We can provide you training, resources, and a list of volunteers in your area to get started. Once a state is well positioned for legislation, a ballot initiative, or court case, Compassion and Choices will provide the requisite political or legal advocacy support as well. And once a state has a medical aid in dying law in place, Compassion and Choices works with physicians and healthcare systems to educate them and provide support for implementing the law in those states. We also support volunteer outreach efforts to educate individuals and families about how to access the law. So why are we doing this? Medical aid in dying is broadly supported by most Americans. Every major poll shows that even though medical aid in dying is not yet authorized in all states, it enjoys broad support across the country. In fact, evidence is clear that medical aid in dying commands long-term, bipartisan majority support among Americans. Independent pollsters such as Harris, Gallup, and Pew all put support for medical aid in dying somewhere between 65 and 75% nationwide. This is consistent with the results of state polls. The American public supports medical aid in dying by large majorities in both independent national and state surveys. Similarly, state-by-state polling also indicates majority support across demographic groups. As you'll see in the next few slides, states as diverse as California, Hawaii, Maryland, Minnesota, New York, Tennessee, and Colorado show clear majority support for medical aid in dying. In California and Hawaii, over 70% of those states' residents support medical aid in dying. And this polling was consistent across genders and ethnicities. A September 2015 Eagle Point Strategies poll showed that 77% of New York State voters support medical aid in dying. This same survey found that clear majorities extend across lines based on respondents' religious affiliation, level of education, political party enrollment, gender, age, and region of the state. And in Tennessee, a 2015 survey conducted by Princeton Survey Research Associates International and Vanderbilt University found that 55% of Tennessee voters support medical aid in dying. They agreed by a 17-point margin that doctors should be permitted to assist people with painful, incurable diseases to painlessly end their lives. What's more, nearly 2/3 of voters, 65%, supported some sort of option for ending one's life due to health concerns. So what are the objections? The three strongest objections are those that are faith-based, others based on the misconception that doctors do not support medical aid in dying, and further objections based on a fear of misuse, coercion, and a slippery slope. Although those who are opposed to medical aid in dying are very vocal, polling demonstrates that these objections are by and large held by the minority. For example, most faith groups, including 70% of Catholics, 59% of people who identify as Christians, 53% of Protestants, and 70% of people from other religions support medical aid in dying. Further, there are numerous examples of faith leaders who support the medical practice. Among them are Desmond Tutu, Archbishop of Cape Town, South Africa, Hans Kung, Catholic priest and theologian, and Reverend Dr. Paul Smith, Presbyterian minister and civil rights advocate. Further, a 2016 online survey conducted by Medscape of 7,500 U.S. doctors representing 25 medical specialties indicates that doctors in the United States support, by a 28% margin, the decision of a patient with an incurable and terminal disease who wants to end their life. By the same margin, doctors say that they would also want this option for themselves. That's 57% of American doctors who believe that medical aid in dying should be allowed. In addition, leading national professional medical associations support medical aid in dying because it empowers physicians to respect their patients' wishes. The American Public Health Association, the American College of Legal Medicine, the American Medical Women's Association, and the American Medical Student Association support open access to medical aid in dying. Additionally, after reviewing the California End-of-Life Option Act, the California Medical Association, which is the nation's largest state medical association, removed its opposition to medical aid in dying legislation. In an historic press release, they said, "We believe it is up to the individual physician and their patient to decide voluntarily whether the End-of-Life Option Act is something in which they want to engage. Protecting that physician-patient relationship is essential." Compassion and Choices is working with state medical associations and other groups around the country to expand support for and access to medical aid in dying. Some people worry that medical aid in dying is a slippery slope that will put vulnerable people at risk. Jean Hughes, who lives with a disability and has worked at the Resource Center for Independent Living for 23 years, contradicts this notion. In his words, "My life cannot be diminished by aid in dying. My life would be empowered by medical aid in dying. It would give me the autonomy I've worked so hard to maintain since my very first day in a wheelchair." Medical aid in dying is not a disability issue, it's a human issue. People living with disabilities support the notion that individuals should have the right to choose medical aid in dying by clear majorities, and often in the same percentages as the general voting population. Still, questions are fair and reasonable, but let's look at the facts rather than misinformation and fear. No abuse of any medical aid in dying laws has been found in the combined states' 40-plus years of experience with medical aid in dying laws across those states where the practice is authorized. In fact, end-of-life care has improved in Oregon since the law was passed. Data show a 30% increase in referrals to hospice care. 69% of doctors took continuing education classes to improve end-of-life care. 70% were more willing to increase morphine dosages to control pain, and 76% felt better equipped at pain management. Furthermore, the leading disability rights organization in Oregon, aptly named Disability Rights Oregon, has never received a complaint that a person with a disability was coerced to make use of the Death with Dignity Act in the 20 years the law has been in effect in that state. If in your conversations with people, they bring up a specific instance of abuse or coercion in Oregon or elsewhere, make sure you take down the information and say you'll get back to them. There are about 10 stories that the opposition uses over and over again, and we have information about each one of them and citations to the news accounts that tell the real story in each case. If there's a new one, we need to know about it. There are some key messages to know, to keep in mind, and to share in your conversations with others about medical aid in dying. These messages help dispel many of the myths that exist about the practice. And because these messages are so important, I will read them aloud one by one. Everybody should be able to make end-of-life decisions that are consistent with their own faith and values. We should have the right to learn about all options at the end of life that will help us have the kind of death we want. And we should have the right to decide which option is best for us. Medical aid in dying is one of several end-of-life options that should be available to people who are dying, in addition to access to hospice and quality palliative care. I may not decide to utilize aid in dying at the end of my life, but it would give me peace of mind to know that I have the option to do so. While hospice and palliative care can help most people most of the time, for some it's not enough. For them, medical aid in dying should be an option. All of the existing medical aid in dying laws provide that no patient can be forced to use the law, and no physician can be compelled to participate. In addition to key messages, it's important to know the correct terminology and understand why we use the words we use. For starters, medical aid in dying is not suicide. People who use it would prefer to live, but they are already dying from a terminal disease. Most people who access medical aid in dying are already receiving optimal end-of-life care in hospice. Medical aid in dying is also not the same as euthanasia. In medical aid in dying, the dying person self-ingests aid in dying medication, and in 1/3 of cases they never take it at all. This means that the person remains in complete control of medical aid in dying, unlike in euthanasia, in which somebody else administers the life-ending medication. Also referred to as death with dignity or end-of-life option, both of which are based on names of state laws, medical aid in dying is one end-of-life option among others for people experiencing a prolonged, difficult dying process. Some people choose palliative care or pain management alone for their final days or weeks. Others may choose VSED or voluntary stopping eating and drinking, or stopping artificial ventilation or other life-sustaining therapies to advance the dying process. The more options we have, and the more information we have, the likelier it is that we can make medical decisions that are consistent with our own values, beliefs, and priorities. Now that we've got the key messages and correct terms down, it's time to go over answers to some frequently asked questions. If someone asks you how the various medical aid in dying laws differ, you can respond by explaining that the medical aid in dying laws in statute in Oregon, Washington, Vermont, California, Colorado, and Washington, D.C. are all similar to one another and are based on Oregon's law. Each has core protections in place to make sure the laws work as intended. You may recall that we've gone over some of the core safeguards which require that anyone seeking medical aid in dying must be terminally ill and mentally capable of making their own decisions. They must make the request on their own behalf, and similarly, they can withdraw the request or decide not to use the medication at any time. And finally, they must self-ingest the medication. If you are asked whether the legislation that Compassion and Choices supports allows people with Alzheimer's or dementia to access medical aid in dying, your answer should always be clear. No. We only support bills that require that a person be capable of making their own decision. None of the states that authorize medical aid in dying allow people who cannot consent at the time they want to take the medication to empower someone else to make the decision for them, for example, as a healthcare proxy or by specifying that they want medical aid in dying in a living will. We are often asked what medications are used. Prescriptions for medical aid in dying typically involve 3 separate medications: a drug to speed absorption, another to prevent nausea, followed by a short-acting barbiturate. Capsules are broken open and the contents mixed in water. Patients drink the water and then normally fall asleep within 5 to 20 minutes. Respiration slows and then stops. Families report that it is a peaceful death. Another question we typically receive is about a cure that might be right around the corner. They ask whether medical aid in dying is cheating people out of this possible cure. For example, HIV/AIDS was a terminal disease and now can be managed as a chronic illness for many years. Newly discovered cures may work for people in early stages of an illness, but they do not rescue a person close to death. Some may be in the early stages of a disease or early treatment, and it may work. Only the person who is dying can, with advice from loved ones, decide when a time comes to acknowledge impending death and take medication to help them pass peacefully. Many people who obtain the prescription actually do not use it and die naturally, but it gives them a great deal of comfort and peace of mind to know the option is available should their pain and suffering become too great. This is a grassroots movement, and we are relying upon you to help push it forward and make medical aid in dying the law in every state. Whatever you like to do, we have a place for you. However much time you have, we can use your help, and you will not be alone. We'll give you the information, training, and materials needed to accomplish the activities you take on. We have tons of different types of volunteer activities that you can get involved with, either leading or supporting. Your first step for getting involved is by joining your local action team, or if there isn't one in your area, consider leading an action team. Action team leaders work directly with our state and regional campaign and outreach managers to implement strategically designed goals and related activities with the help of their team members. On-call volunteers help with specific projects that come up periodically, and generally with short notice, such as phone banking. If you're interested in being an on-call volunteer, let us know by sending an email to volunteer@compassionandchoices.org. You can work on activities in the field. Media-savvy volunteers can help out, advocacy volunteers can get involved, and finally, volunteers who are active in local political activities or who are connected to your city, town, or county elected officials can take the lead on getting a local resolution in favor of medical aid in dying passed. If this is of interest to you, contact volunteer@compassionandchoices.org to get started. So what are we talking about when we say you can work in the field? Examples of field activities include gathering petition signatures, getting postcards to lawmakers signed, promoting our Ask Your Doctor campaign, hosting a house party, staffing a table or booth to educate and engage people in your community. Media-savvy volunteers can help out as well by writing letters to the editor, writing an op-ed, liking us on Facebook and participating in social media, calling in to radio shows, searching for storytellers in the comment sections of news stories, or commenting on news stories. And advocacy volunteers can get involved by visiting elected officials in your district or capital offices in states where medical aid in dying is not authorized, writing a letter to your elected officials articulating your support for the practice, or in states where medical aid in dying is authorized by writing to other stakeholders, such as hospital administrators. You can show up at community events where medical aid in dying is being discussed, and you can participate in lobby days. In addition to all these other volunteer roles, we also need storytellers. You may remember Brittany Menard, a 29-year-old Californian who brought international attention to medical aid in dying when she had to move to Oregon to utilize its Death with Dignity law, which she used to end her suffering from terminal brain cancer on November 1st of 2014. Her courage has inspired many to share their own personal stories, moving countless people to action, and our movement has grown exponentially as a result. What we learned from Brittany's telling of her story is that personal stories speak to people's hearts and to shared values. People don't generally remember facts and figures, but they remember stories. And this is because stories ground policy in real life. Talking about real people humanizes the information, which depoliticizes the issue. It becomes about someone who will be helped by changes to the law, and this opens doors. In areas where it's difficult to discuss the law or the reform effort, sharing a simple story is a way to open a dialogue. To think about telling your own story, start by answering these questions. Who are you and why did you get involved in this movement? Why does access to medical aid in dying matter to you? Were you a witness to a bad death? Do you know someone who was? What are your wishes surrounding how you do and don't want to die? I hope it's clear by now that this is not a spectator sport. To be successful, we need you to get actively involved. Compassion and Choices supports all of our volunteers with a full suite of materials and resources. If you've signed up to volunteer with Compassion and Choices, you should already have received the most recent quarterly action bulletin via email. You can also find current and previous quarterly action bulletins in the Volunteer Resource Center on the Compassion and Choices website. Quarterly action bulletins represent the organization's highest current priorities for volunteer efforts and give you specific actions that you can take to make an impact right now. Beyond the website, another great resource for you are our training videos. Visit Compassion and Choices Volunteer Resource Center webpage to find our training resources, as well as our brown bag webinars. And also, we have tons of toolkits and materials with the best practices and step-by-step guides to help you take action. And now, here are your next steps. First, review the medical aid in dying related fact sheets linked on the Volunteer Resource Center webpage. Second, refer to the most recent issue of the Quarterly Action Bulletin and start taking the actions that are listed. And finally, if you're part of a local action team, let your team leader know you've completed this training and you're ready to get involved in your action team's medical aid in dying advocacy activities.